everyone. Now I'm going to talk about placenta accreta spectrum. Now, placenta accreta spectrum recently has gained a lot of importance because it is leading to bleeding, right? And although this bleeding is happening in the postpartum period and patients present with an intractable PPH, but I am talking to you about placenta accreta spectrum in bleeding in pregnancy section. This is because placenta accreta spectrum, for placenta accreta spectrum, one of the very important risk factors is placenta previa. So in all patients of placenta previa, you should suspect placenta accreta spectrum. And when you suspect placenta accreta spectrum, what are all the findings you have to look at? That is very, very important. So I am dealing with placenta accreta spectrum over here, right? Now, placenta accreta spectrum, it was earlier called as morbidly adherent placenta. Now, what happens in this entire spectrum of diseases that the villi of the placenta, which are normally attached to the endometrium or to the decidua, in case of placenta accreta spectrum, they are not attached to the endometrium or decidua, but they are either attached to the myometrium or they infiltrate the myometrium. Now, depending upon where the villi are attached, this placenta accreta spectrum has got three kinds of placentas included in it. Number one is a placenta accreta, which is the most common variety. Right? In placenta accreta, the villi are attached superficially to the myometrium. So as you can see over here in the image which I have drawn, the blue color is the endometrium or the decidua and yellow is the myometrium. So in number one, the villi are attached superficially to the myometrium and that is what is called as placenta accreta. Then we have placenta increta. Placenta increta means that the placental villi are infiltrating into the myometrium increta. And then we have placenta percreta, which means that now they have passed through the myometrium and now they are attached to the serosa. So when the placental villi are attached superficially to the myometrium, that is accreta. When they are infiltrating and they are attached deeply into the myometrium, that is increta. And when they are attached to the serosa of the uterus, that is placenta percreta. Now, FIGO has given a classification for placenta accreta spectrum, grade 1, grade 2, grade 3, where grade 1 means we are dealing with placenta accreta, grade 2 means we are dealing with placenta increta, and grade 3 means we are dealing with placenta percreta. Now, if placenta percreta mein, the villi are attached to serosa, then it is called as grade 3A. If the villi are attached to the bladder, they after infiltrating the serosa, they reach up till the level of the urinary bladder, that is grade 3B. And if the villi are attached to the pelvic structures, any other pelvic structure, then that is called as grade 3C. Right? Now, what is the etiopathogenesis over here? There are two common pathological factors which are seen in any of the placentas which are included in this entire spectrum, placenta accreta spectrum. Number one, in all these three conditions, there is either an absent decidua basalis or there is a defective decidualization. And number two, the Nita-Books layer. So see, Nita-Books layer is a layer of fibrinoid degeneration which is present between the trophoblast and decidua basalis. And it is this layer which guides the penetration of the blastocyst. So it tells the blastocyst that you have to go this much deep and you don't have to penetrate any deeper. Now, if Nita-Books layer is absent, this blastocyst which was penetrating inside the decidua, it is lost. It doesn't know that where I have to stop penetrating. And in this case, what happens is that the blastocyst goes deeper and deeper, and that is why chorionic villi are now not attached to decidua basalis, but they are attached either to the myometrium or to the serosa, or then they can infiltrate further and they can reach the level of urinary bladder as well. So, these two conditions are important for development of placenta accreta spectrum. Number one, defective decidualization, that is absent decidua basalis, and number two, absence of Nita-Books layer. Now, a third possibility is that there is hyperinvasiveness of the cytotrophoblast, and a possibility says that it is this hyperinvasiveness of the cytotrophoblast which may also play a role in development of placenta accreta spectrum. Now, when we talk about risk factors, as I told you, there are two factors which are very important. One was the defective decidualization and another was absent data books layer. Similarly, in risk factors also, there are two very important risk factors. Number one, if presently in present pregnancy patient has placenta previa, and number two, if she is a case of previous history of cesarean section. So if there has been a cesarean section in the past, then these are two very, very important risk factors for placenta accreta spectrum. Amongst these two risk factors, again the most important one is previous history of cesarean section. Not only is previous history of cesarean section a very important risk factor, but as the number of cesarean sections are going to increase, the risk is also going to increase. Apart from previous history of cesarean section, if there is history of any other uterine surgery like myomectomy, curettage or endometrial ablation, that is a risk factor. Previous history of placenta accreta spectrum is a risk factor, and all the risk factors which we had studied while I was teaching you placenta previa, all those are risk factors for placenta accreta spectrum also. But the two very important, as I told you, is in present pregnancy if patient has placenta previa and if previously there was a history of cesarean section, most important being previous history of cesarean section. Now, like two risk factors, two important risk factors, two important etiopathogenesis, there are two important markers also which are being studied. So, when a study was done on patients who had placenta accreta spectrum, it was seen that in most of the patients, the maternal serum alpha fetoprotein levels and beta HCG levels were higher, right? Although currently, they are not being used as a test for placenta accreta spectrum, but then they are being taken as the markers of this disease, that if maternal serum alpha fetoprotein levels are more than equal to 2.5 MOM, similarly, if beta HCG levels are more than equal to 2.5 MOM, where MOM stands for multiples of meridian, then there are higher chances of placenta accreta spectrum. Now, for the diagnosis of placenta accreta spectrum, the investigation of choice is ultrasound, and better answer would be ultrasound with color Doppler. Placenta accreta spectrum is associated with some characteristic findings on ultrasound, and these findings are present from second trimester. So when you do an anomaly scan, you can come to know that you are dealing with placenta accreta spectrum, and then a definitive diagnosis can be made by 28 weeks. So investigation of choice for placenta accreta spectrum is ultrasound with color Doppler. Now, Williams Orbs 26th edition, page 762 says that there are 5 characteristic findings, ultrasound findings, which should tell you that you are dealing with a case of placenta accreta spectrum. Number one is, if in the placenta you are getting large placental lacunae or placental lakes, right? So normally a placenta is homogeneous in appearance. Now, if in the homogeneous appearance of placenta, if you start getting sonolucent areas, right, black areas there, which represents placental lakes and which gives the placenta a moth-eaten appearance, that is one characteristic finding in case of placenta accreta spectrum. See, normally also in placenta you may get placental lakes, but then those placental lakes are very small. If you are getting a large number of placental lakes which are big, which are irregular, and when you switch on the color Doppler there is increased vascularity in the lacuna, then it tells you that you are dealing with placenta accreta spectrum. So look at this ultrasound over here. This homogeneously appearing area is the placenta, and in the placenta, can you see this echogenic area, sonolucent area? This sonolucent area is representing these black areas. They are representing the placental lake, and when a Doppler was switched on, we saw that there was increased vascularity, right? So that is first finding which tells you that you are dealing with a placenta accreta spectrum. Number two, you are going to get thinning of the retroplacental myometrium. That means distance between the serosa and myometrium will be less than 1 millimeter. Then you are going to get bridging vessels from placenta to the serosal interface. So there will be bridging vessels which are going to be present from this abnormal placenta. Vessels are going to arise, and these vessels are going to go up till the bladder serosa interface. Now, because vessels are arising from these vessels from the placenta and they are going up to the bladder serosa interface, and this is typically seen in placenta accreta. So what is going to happen? Normally, you get a white line, a continuous white line which reflects the bladder and the uterine serosa interface. Now, imagine if blood vessels are running from the placenta and they are reaching up till the bladder serosa interface. This white line, which was initially a continuous line, it will be broken. Right? So you are going to get disruption of the continuous white line reflecting bladder uterine serosa interface. And why has this disruption happened? This disruption has happened because vessels have grown from the placenta and they are going up till the bladder serosa interface. So when you are going to switch on the Doppler, you are going to see hypervascularity of the serosa bladder interface. Then, last finding is related to decidua basalis. Normally, when you look at the placenta, below the placenta, you get a hypoechoic area which represents the decidua basalis. Now, in case of placenta accreta spectrum, there is no decidua basalis, so you are going to get loss of a normal hypoechoic area behind the placenta representing decidua basalis. So out of these findings, if you are getting any finding that indicates that yes, you are dealing with a placenta accreta spectrum. Now, generally, MRI is not needed for diagnosing the placenta accreta spectrum, but based on ultrasound and Doppler, if the diagnosis cannot be made, then you have to go for an MRI. Now, once I have diagnosed in the antenatal patient that in the antenatal period that my patient has got placenta accreta spectrum, so ACOG says that in such a case, I know that I will not be able to separate the placenta, and if I will not be able to separate the placenta, eventually I will have to do hysterectomy. So in this case, what I'm going to do is I'm going to plan a cesarean section between 34 weeks to 35 weeks, 6 by 7 days. That means up till the end of 35 weeks. So at the starting of 34 weeks until the end of 35 weeks, I'm going to plan a cesarean section, which should be followed by hysterectomy. And this hysterectomy you are going to do with the placenta in situ. Now, for this kind of plan where you are going to initially do a cesarean section followed by hysterectomy, general anesthesia is preferred, and then I am not worried as that I have to do a lower segment cesarean section. Most of the times even you are going to get a placenta previa there, so it's better that you do a classical cesarean section avoiding the placental site. Normally we do not do a classical cesarean section. Classical cesarean section means that you are giving incision in the upper uterine segment. Normally we do not prefer a classical cesarean section because after a classical cesarean section, if a female conceives, the chances of uterine rupture are high, and so you have to do a cesarean section. But in this case, I'm going to do a hysterectomy, right? So I am not worried about uterine rupture. My worry is that I should deliver the fetus without cutting this area which might have a placenta previa as well. Right? So I am going to do a classical cesarean section, avoiding the placental site. And once the baby has been delivered, then I'm going to close the uterine incision. I am not going to make any attempt to remove or deliver the placenta. No attempt should be made to deliver the placenta or to separate the placenta. And once you have closed the incision site, you should do a hysterectomy. Why are you closing the incision site? Because otherwise, till that time, patient will keep on bleeding. Now, preoperatively, ureteric catheterization is helpful, and this ureteric catheterization is going to help you to identify the ureter and help you in dissection in case the placenta invades the bladder. So in case it's a grade 3B kind of a placenta, then a ureteric catheterization is going to help you in locating where the ureter is, and it will help you in dissection so that you do not injure the urinary tract. But then studies have shown that even if you are doing a ureteric catheterization, it does not decrease the risk of urinary tract injury. But then in practice, we do a ureteric catheterization. Then some of the studies said that since we know that patient is going to bleed, why not do an arterial catheterization of the internal iliac artery with the balloon catheter? So once the baby is delivered, before that only, first we put an balloon catheter in the internal iliac artery, but we do not inflate the balloon. And once the baby is delivered, we inflate the balloon of that catheter so that, the blood flow to the pelvis decreases and the bleeding could be reduced. But then this is not recommended, but it leads to increased chances of embolization, and so it is not recommended by ACOG. ACOG says you want to do a ureteric catheterization, that's okay. We are not saying that you shouldn't do it. But then arterial catheterization has a very big disadvantage that it can lead to increased chances of embolization. So ACOG does not recommend arterial catheterization. Right? So this is how you have to manage a placenta accreta spectrum if it is diagnosed antenatally. But by chance, you are not able to diagnose a placenta accreta spectrum in antenatal period, or patient did not come to you for any antenatal checkup and patient has come straight to you after delivery. How is this case going to present to you? In this case, patient is going to present to you with intractable PPH. The plane of cleavage for placental separation will not be obtained and you will not be able to separate the placenta. And occasionally, placenta percreta may infiltrate into the bladder, giving rise to hematuria. Now, in this case, once the placenta accreta spectrum diagnosis is made after delivery, then you are going to go for emergency hysterectomy, right? Now, there would be a few females for whom this would be their first pregnancy, or they would want to preserve their uterus. In that case, the placenta is left in situ. Cord has to be ligated as close to the placental insertion as possible. And suppose, you had delivered the baby by cesarean section, you had diagnosed it in antenatal period, you had discussed the condition with your patient, and patient had said, no, you do a cesarean section, deliver the baby, but I am not ready giving you consent for hysterectomy. So immediately, once you've delivered the baby, you leave the placenta in situ. Cord should be ligated as close to the placental insertion as possible, and the hysterotomy incision should be closed. Now, in this case, because you are not removing the placenta, patient will bleed, and this bleeding should be controlled by compression sutures or by packing. You should do serial ultrasounds and MRI in them. Serial beta HCG levels are not useful, and ultimately, 20% of these patients will need hysterectomy sooner or later. Earlier, we used to say that if you are leaving the placenta in situ, you should give such females injection methotrexate, but now that is also not recommended. Right? So this is how you manage a placenta accreta spectrum. Ideally, this thing is that you will have to do hysterectomy, but only in few females, they are going to say that I am not ready for hysterectomy. You are going to leave the placenta in situ, but then that becomes a very big challenge. So I hope you've understood placenta accreta spectrum. Do not forget that in all patients who come to you with placenta previa, or in females who come to you with previous history of cesarean section, do not forget to suspect a placenta accreta spectrum. Take care. Bye-bye.